Well, good morning and praise the Lord, everybody. Welcome to the Chew. Welcome to the Chew. Thank you for joining us this morning. We are the Committee of Health, Education, and Wellness of the Pentecostal Assemblies of the World, International Incorporated, and our international provider and presider and prelate is Bishop Theodore Brooks. And our chairman of this chew is Bishop Dr. Roland Harrison. You'll hear from both of them a little bit later on this morning into further discussion, so you don't want to miss them. Well, we're having a roundtable this morning, and so at this roundtable, we're going to be discussing the latest information on COVID, the pandemic, and its impact on us as an African American community, our concerns, our fears, and a lot of disinformation. We're going to learn how we can protect ourselves, our families, and the people that we love. We've all been impacted by this devastating pandemic. It's been something that has changed our lives. It's changed the way we do church. It's changed the way we work, the way we do schools, even how we conduct ourselves in hospitals. It's just changed our whole life. More specifically, in the African American community, we were the hardest hit. And the statistics concerning that is just alarming. I think if we think about it, nearly a third of all the infections nationwide, African American community was affected the most, and we represent only 13% of the U.S. population. So it's quite an issue among us, and we'll talk more about that as we move on. But the most important thing is that we want to get back to how and ways that we can congregate, fellowship, and just do life together, go to family reunions, concerts, and do things like that. But even more important than that, it's important that if we are able to do that and when, that we do it very safely. So that brings us where we are today. Before we get started in our roundtable discussion, I'd like to introduce our distinguished panelists today and our very special guest that we have assembled for you this morning. Firstly, I'm Dr. Lillian Lockett Robertson. I'm a practicing obstetrician and gynecologist. I am a women's health specialist, community health and wellness ambassador, conference speaker, and I'll be your moderator today. With us also is Dr. Ray Van Key. Dr. Key is a licensed clinical psychologist. He's a change coach. He's also a mental health and corporate wellness consultant and an international speaker. Welcome, Dr. Key. We also have with us this morning Dr. Marion Wright. Dr. Wright is a licensed clinical psychiatrist and specializing in neurological sciences and psychiatry. Glad you're here with us today. Dr. Karen Douglas, she is a licensed clinical psychologist. She's a tenured professor of psychology, international speaker on health and wellness and spirituality. Dr. Douglas is pursuing a master's degree in psychopharmacology to become a prescribing clinical psychologist. And so we welcome you. And with us also this morning, we have our special guest, Dr. Jane Morgan. Dr. Morgan is a cardiologist. She's a researcher. She's the clinical director of COVID task force at the Piedmont Healthcare Corporation of Atlanta. She is a frequent guest on CNN and many other major national platforms. She champions ongoing community outreach in conjunction with the Division of Diversity and Inclusion between Piedmont Healthcare and the African American people that they serve. So we're grateful to have you, Dr. Morgan, and welcome everybody. We're glad you're here. So doctors, we just want to have this as a organic conversation. We're going to talk and discuss our own feelings, our fears, topics about COVID, and what we've learned this past year and a half or so based on our clinical experiences, what it's taught us. So let's just jump right in. We're amazed that we have 3 vaccines. We have the Pfizer BioNTech, the Moderna vaccine, the Johnson & Johnson, and I think that's awesome. But what's more striking to me, Dr. Morgan, is the fact that according to the CDC, so many of us were impacted as an African American community. 1/3 of the infections nationwide affected us. Studies of Yale found that we were 3.5 times more likely to die from COVID when we got it than white people. And the same is true in the Latinx community. Why do you think African Americans were just so hard hit by COVID among and above other groups? What do you think has happened, and why are we in that state?
Yeah, thank you, Dr. Robertson. And I think I'll add to that that we know now that during this pandemic, which really has gone on for about 14 months, that African Americans have also lost 3 life years from our life expectancy in just 1 year. And so, why have all of these things happen to us? Certainly, we live within the societal construct of America, with ongoing social unrest and infrastructure that leads to a lot of what happens to us. We certainly see more the SDOH, all of the ways that we live, and all of the ways that we have been construed to live within these areas has been an ongoing effort. And so, one of the things that we noticed is that we have this tepid relationship with the medical system because of, all of historical context. We have really no relationship with research at all because of the same thing. And then we also have an ongoing uneven relationship with the U.S. government. And so all these three things came together to bring us these vaccines. And so we shouldn't be surprised that there is vaccine hesitancy.
So that's really interesting. It's really, when we talk about it, we're talking about policing, social determinants of health, where we live, learn, work, and play. All those things and the policies surrounding all of that really does impact us more. So, we think of it in terms of, social justice, but it's also health equity that gets impacted by that. So thank you for that. And I'm often reminded of, when America catches a cold, Black people get the flu. So it's really kind of interesting when that happens. But, I don't know if any of you guys are just seeing a lot of this, how COVID has just become so political. The whole notion of the coronavirus, it's to wear a mask really signifies who you voted for or who you didn't vote for. And are you getting that feeling when you kind of see folk in masks or resisting to masks? Here we are dealing with a pandemic and it's being politicized. That kind of bothers me. I don't know if you guys are bothered by that.
Yeah.
I'm definitely bothered by it. I was watching the news the other day and I realized that this whole mass confusion, it feels political. And what the news was actually saying is that, the CDC's decision to say that if you have been fully vaccinated, you can decide to wear a mask or not, is actually an experiment. This is what they said on the news. This is the government's way of getting some data and not really information, or this is what people are saying, or this is what I got from the news, not really like based in truth, but is more of an experiment to see how things turn out as people begin to take their masks off. And I know for the Black and brown community, that could be, disheartening, that could be scary. And I'm wondering if anybody else has heard this as well. Because when I talk to my clients, they have all different types of understandings of what these, changes are in terms of restrictions and lifting of restrictions. And they don't know whether they can really, truly trust it or not, because they don't know whether they are part of an experiment. Still, that feel is there.
I've heard that as well, that many of my patients and the people that I interact with, they do feel that it is an experiment and they don't trust not to wear the mask. And when I've been in neighborhoods that were not necessarily primary of color, they, as you stated, Dr. Lillian, they tend to be more comfortable with not wearing a mask, to the point where sometimes I've been in stores where I've had to ask people to back up, that you're too close to me, and they kind of look, and some are offended. or if you just don't want to interact with them because of the fear or the anxiety that may be provoked because they don't wear their mask, where you don't necessarily, or I haven't experienced that in the African American community. We tend to be much more serious about wearing masks, much more serious about social distancing. Now, the fact of getting the vaccine, that may be another issue.
And from what I've seen, well, what I tell my patients, of course, mental health patients who are already dealing with depression and anxiety and things of that nature, this is a time that could certainly increase their anxiety. But I tell a lot of them that what they pretty much have to do is choose the places that they go kind of based on what the scenery looks like. Personally, there are some places I don't go because there seems to be a blatant disregard for even signage saying, hey, you have to wear a mask to enter here. And so, if I see that, I'm like, well, maybe this is somewhere I need to stay away from, because even if I wear mine and everyone else isn't, then, what good is that? So I try to pass that along to my patients as well.
Dr. Wright, I hear what you're saying, that you kind of monitor where you go, but that kind, and I get why you're saying that, but for me, it's a little concerning that I can't go to places that I want to go because people don't want to wear masks. So I don't even know how that could be addressed, but I just don't know if I would stop going where I want to go because of that. And maybe I'm just a little bit different, than my personality may be a little bit different than yours. But I just would like to know how others would think about, would you not go where you want to go because someone doesn't want to wear a mask? And is that a form of controlling you? And I think a lot of my patients have said that with the whole pandemic thing, it's about manipulation, control, and intimidation.
So one of the things I want to add to that, just from a scientific perspective, when Dr. Rochelle Walensky, the director of the CDC, came out to announce the update in the mask mandate, one thing that she was really looking at is just the scientific data on people who've been immunized and are 2 weeks beyond their second dose of vaccination. And what does that confer? What is the data showing us with regard to protection? So those people who are fully immunized actually are very unlikely to contract a symptomatic case of COVID, even if they were to come in contact with it. If they were to contract COVID, because remember, these vaccines are not 100%, their course of disease would be very, very mild, maybe even asymptomatic. They may not even be aware that they have it because of the immunity of their systems with these vaccines. Additionally, because of their full immunity, any viral load that they carry is so low that if they were to come in contact with people who are unimmunized, they are less likely, almost unlikely, to pass that disease on to others because they have so few viral particles inside of them. If in fact they were to pass this disease on to someone else, because there are so few particles, that person who contracts COVID would also be expected to have a very, very mild course. What we know is the progression and the severity oftentimes of the disease is related to the inoculum that you receive, the amount of virus, the particles that you receive in your exposure. And so I believe that that is why she moved forward to say, if you are immunized, you should feel safe because you are protected. You are even protected from those around you who are unprotected. So your vaccination not only protects you, it also protects those around you. Now, that being said, I can certainly understand how everything started to become confused because there were many scenarios that weren't considered. So for instance, if you are in a restaurant, supermarket, a closed situation, and you're unmasked because you're fully vaccinated, other people are unmasked because of whatever their political ideology may be. Nobody knows who's who. And even though as a vaccinated person, you should still feel fairly comfortable there, you could be bringing unvaccinated people with you, like your children. And so now you've brought them into a situation where everybody's unmasked, so they're supposed to be vaccinated, but some are and some aren't. Are you now exposing your children or other people in your household who haven't been vaccinated? So I think she was trying to follow the science. I think also she probably had some political pressure as well. But I think it's very difficult. And certainly we're here in Georgia where at the time that she announced it, the immunization rate, I think, was only 21%. The majority of the state wasn't even immunized. And so it's an uneven distribution. Some states clearly have been much further out ahead of where this is than we are. So I think those are some of the things when, we're talking with patients, we can temper some of that anxiety to say that this decision was based scientifically. And it was based scientifically on how these vaccines protect people who are fully immunized and what that means as a society. But then we have all of these other what if situations, that occur.
And Dr. Morgan, thank you for that. And I hear what you're saying as a scientist, but as a clinician working with people that are very distrusting of the government. And I probably will not or could not say it as eloquently as you did. I don't know if trying to explain that to my patients or people that I know in general, if it would come off as eloquently as you have said it, therefore maybe not giving them the proof or the comfort in being around people and understanding why it's not necessarily for us to have a mask, even if we are, we have the vaccine. So I guess I would like to hear if it's just me or if it's some of the other panelists. How do you guys, not as scientists, actually convey that information to your patients? And then another thing I would like to hear is that what is the liability if you do tell someone to go get vaccinated, or you don't have to wear your mask because the likelihood of you getting the virus and the level of the intensity of the symptoms is less, when you're telling that, because a lot of our patients, they depend on us, they rely on us, and they believe what we say.
So Dr. Douglas, I just want to respond really quickly to that, and then I'm going to have everybody else respond. So I think you hit the nail on the head. This entire vaccine rollout has been mishandled and is confusing. And there's been lack of education and there's been lack of communication at every single step of the way. Lack of education ahead of announcements, lack of education ahead of authorization of these vaccines. We don't have approval. We have authorization. What does that mean? Messenger RNA, what's that? But, nobody has any information. If you don't live in the scientific world, none of it makes really good sense. And so I think you make, a really excellent point that in multiple steps along the way, it has been confused and people are getting their information from media who may or may not be confused as well. And we're not getting it directly from scientists, and scientists have kind of lost their voice in this process. So I think you make a very good point.
So then what is the right thing for us to do within the African American community? We are the least vaccinated. Once exposed, we are more likely to be sickest and die from the health disparities and issues. And so I was just telling the other day, I was at the florist buying flowers. And so the young lady that was waiting on me, I asked her, once the mask mandate was issued by Dr. Walensky, I asked her politely, because I had been vaccinated, have you been vaccinated? And she says, well, why don't we let's keep talking about the flowers? So I said, okay. But it's just one of those things. And so what is the right thing to do? Do we just wait until we reach herd immunity, or we, just say, okay, since I've got it and I'm good, then everybody else is good? Can you give us something to take away that in a way that we can use this when we're in the street, or obviously when we talk to our patients?
Yeah, so a couple of things. So the vaccines in the African American population, and even though these vaccines they're at 94.5% for Moderna, 95% for Pfizer, 72% in the US for Johnson & Johnson, 66% globally. They are at 100%. And that's what we have to remember. They are 100% in preventing death and in preventing hospitalizations. And so people have to remember that getting the disease is not 100% in preventing death. You now have a risk of dying. The other thing we have to think about in African-American community is that these vaccine companies very specifically were intentional and purposeful in enrolling African Americans in these trials. And in general, for all of the historical atrocities that, you know, we can or can't discuss, whatever we'd like to do today, we don't really participate in research at maybe 3 or 4% clinical trials, but clinical trials are our access to healthcare, but we don't participate in that. And so to see these trials, Moderna enroll at 10.3% African Americans, Pfizer at 9.8%. These vaccine companies were intentional and purposeful. I wrote a scientific paper and analysis last summer of Moderna's phase 1 and phase 2 vaccine programs that was highly critical of them, highly critical of their practices, of their processes, of their exclusion of Blacks in these trials, of this pandemic that was impacting African Americans. At that point, they had only included 2 people in their trials. And I mean a whole number, 2, not 2%. By the time they completed their phase 3 program of 30,000 people, and by the way, Moderna called me and we had a conversation. And to their credit, they said, we read your paper and we have decided that we can do better. So that's one understanding of where these companies are. So for them to recruit that number of people, we have 30,000 in Moderna, 40,000 in Pfizer, that's 70,000 people, an average of 10% African Americans. That's 7,000 people. We should feel confident that the data that was submitted to the FDA is relevant to our population. When I also look at that very small slice of African Americans, that 10%, those 7,000 people, even though Moderna and Pfizer are at 94.5% and 95% efficacy, when I look only at the Black subpopulation in both of those vaccine studies, and I look only at that data, and I look at the number of Black people who developed symptomatic COVID 2 weeks following that second dose, that number was 0. What that means is, even though the efficacy of these vaccines is 94.5% and 95%, in the Black population, the efficacy is 100%. And so those are the things we need to understand. But I also understand, just as Dr. Douglas has beautifully laid out, nobody really has this information. Nobody really understands it. There's no education. So it's very complex. The only other group that has 100% efficacy is the Pfizer children, 2,260 children, 12 to 15-year-olds in that trial that they now have emergency use authorization. 18 of those children developed COVID. And when they unblinded that trial, all 18 of those children were in the placebo arm, the arm that didn't actually get the vaccine. So Pfizer's vaccine in 12 to 15-year-olds is also 100% efficacious.
So Doctor, go ahead, Dr. King.
I mean, I'm listening to everything that's being said, and you know, as you're talking, Dr. Morgan, I am understanding the science of it. But what about the individuals who care less about the science? Like, I've had individuals tell me COVID is just like the flu. People die from the flu. You know, if you die, you die. If you don't, you don't. You know, we're not making a big deal and causing a pandemic like effects in the world because of the flu. You know what I mean? For some people, it's just the flu, a version of the flu. You know, and they're very intelligent. You know, they're very smart. They know the science, but they want to believe what they want to believe. You know, I've got some people who are like, well, I'm healthy, you know, and you know, it's not going to make a difference whether I take the vaccine or not, because I am very healthy and the likelihood of me getting it or dying is as if I've taken the vaccine anyway.
And Dr. Key, that's interesting that you're saying that, because from my perspective and what I'm seeing is people are more afraid and anxious about, one, getting it, but still on the other hand, getting the vaccine. I had just recently, I got a call that one of my patients that rides public transportation, very cautious in what she does, wearing her mask, but she's in the hospital now with pneumonia. And we had the week before, COVID and, pneumonia. And the week before, we had talked about her getting the vaccine, and she just went off about, especially Johnson and Johnson, going on and on about why would I get the Johnson and Johnson vaccine and the talcum powder thing. I said, well, there are other providers that you can get the vaccine. She was totally against it. And so when you say that people are looking at it more like the flu, as I said, I'm seeing it from a very different perspective. And it's difficult to handle when you have all of these fears and concerns. And again, you're still making sure that when you deal with your patients, that you're not telling them what to do, but you're giving them information. But still, again, like you said, a lot of people don't care about the science. Either they don't understand it or they just don't care.
One of the
So
things
that's
that's really
concern.
one of the things that is that I'm starting to hear a whole lot more, particularly after the vaccines came out, or even before, the conspiracy theories surrounding the vaccine. I'm sure you guys have heard many of them, that it would change your DNA, that it would cause infertility. I have to address that ongoing as an obstetrician, whether or not you will, there was erectile dysfunction or infertility issues, or if the vaccine is bioengineered as a weapon for population control. These things are really true. And this is what we're hearing in the salons. And so it's really tough. I just want to know, is it our personal responsibility to debunk those categories of theories? Or at what point do you just give up and just say, okay, let's just let you do what you need to do and I do what I need to do?
Well, I mean, it's hard to debunk those theories if you are not solid and confident in what you know. As a clinical psychologist, I could never offer the debunking of a theory like Dr. Moore might be able to, or that you might be able to, Dr. Robertson. But if you add on the layer of like faith, I'm thinking to myself, although we're willing to provide the education, it's almost like we have to uneducate people first. They have to unlearn some things first, because what we're educating them about is not penetrating, because there's something else in place. And that's where I find myself a lot of times in the position of, do I have the authority, the competence, and the knowledge to be able to help them unlearn this first before I teach them, or they're able to hear education regarding this thing? And I think that's the hardest piece. Like, for instance, yesterday I posted that I was fully vaccinated. I share on my social media, and I don't know whether this was a coincidence or not, but one of the church members that I know contacted me, and they were concerned for me that I had allowed myself to be injected with a barcode.
Or a chip.
A barcode that would allow the government to trace me wherever I am in the world, and that this was leading to the one world order.
Yeah, no, that's your iPhone that allows the government to track you. They already have their chip with them.
Listen, I know that, but the fact that this person believed that so strongly that they felt a need to call me, it felt like out of concern that, like, you messed up.
So,
and I don't think that we can dismiss that, even though we know that that's not the case. I think we have to be very sensitive about what people are believing. And I know, I just think that, as you stated, sometimes people have belief systems that we have to help them move away from faulty, schemas of how they think and how they feel. But the reality for that person, it was true. They really believe that. And then what can you say to debunk that? Do you really know that that's not the case?
So I'd like to address, Dr. Key, a couple of things back on sort of your flu comments and some of these comments. So what's the difference? So a couple of things, maybe that you could use as a tool in your armamentarium that make it different than the flu. Patients who develop COVID-19 and recover, they don't die. 30% of these patients later on will develop something called long haul syndrome. And long haul syndrome is, at its mildest, loss of taste or smell. You can have disorientation, brain fog, which is mental disability, people unable to return to work, previously healthy young people, 20s, athletic, runners unable to climb 2 flights of stairs, chronic fatigue, chronic inflammation of your heart, it's called myocarditis, chronic inflammation of the lungs. We have no cure for this long haul syndrome. We have no intervention. We have no prevention. We have no medication for it. And 30% of people who develop COVID will go on to this long haul syndrome. And for our youth, it's devastating because just for what you said, many people say, I'll just get it and I'll be pretty healthy. I'm young. I don't have any medical problems. I'll just, whatever, quarantine for 10 days, 14 days, and then spring myself. The tragedy of that, especially for our youth that's primarily healthy, is that down the road, they could be much sicker than they ever were during the course of their quarantine when they were feeling pretty impervious and pretty healthy. And so that's something that we should think about. It cuts across race, it cuts across gender, cuts across age, cuts across religion, cuts across socioeconomic status. It also cuts across level of complication of your disease. That's 30% of people with long-term medical issues that may or may not have even been sick when they had COVID. So that's one thing to think about. The other thing to think about when people say, I'm pretty healthy, I don't take, any immunizations, I don't take anything. The reason for that is because in America, we enjoy herd society, the privilege of herd society. And as long as the slice of our society that is unvaccinated for any of the communicable diseases remains relatively small to the greater population, then everybody benefits. The point of herd immunity is if you get enough of the percentage immune, then these diseases can't find a vehicle or a path to come in. And then everybody is protected, even the unimmunized. So it's not that unimmunized people, for whatever reason, either medical conditions or maybe they're just choosing not to take vaccines in general, it's not that they are somehow healthier or they've evolved to some higher physical state or their immune systems are somehow better than everyone else's immune system. No, they enjoy health because you and I get vaccines. Their health depends on us. So for them to be healthy, they need to make sure I'm healthy, because if I'm sick, my health is predicated on them. They're depending on me since they didn't get vaccinated. They're depending on me to be healthy, to keep the herd healthy. So these are not independent decisions. I have always been healthy. I have some super immune system. I've got some evolved physical status. No, you enjoy herd immunity because people like you and me get our immunizations, and therefore you don't get sick because we are protecting you because we're not sick.
We've always had, Dr. Morgan, we've always had vaccines. I remember as a girl going to get my vaccination. I still have a scar on my left arm, and to travel to Africa. I've been intercontinental. I've done intercontinental travel. So vaccine has always been the issue. But my concern is what's making people feel like this COVID vaccine is not safe for us. We've accepted vaccinations all of our lives, polio, HPV, all kinds of things. And so now we're at a whole new juncture where people are just not trusting this one in particular. So, speak to that and why that you think that is.
So this vaccine represents sort of the three tips of the triangle, especially for population of color. It represents the medical system, where we have a tepid relationship, research, where we have no relationship, and then the U.S. government, where we have an ongoing easy relationship. These vaccines also developed under the previous administration, which was openly hostile to African Americans. We then come out with this new scientific platform called messenger RNA. What is that nobody explained? It then seemed that the vaccines were developed so fast, seemingly just coming to the market, within a year. But the fact of the matter is the SARS-CoV-2 virus, the severe acute respiratory syndrome coronavirus 2, so named because that's an alert to scientists that this is the second time that we've seen it. So when did we see it the first time? We saw it the first time in 2003. When we had our SARS outbreak, at that point, our global pandemic response team was in place. We were able to keep that outbreak largely off our shores, but alarms were going off in the scientific community for a number of reasons. One, it's a virus. Viruses replicate quickly and then have the ability to mutate. And two, it was respiratory borne, airborne. We are Homo sapiens. We are Earth dwellers. We live on a single planet in this entire galaxy. We require air. Unlike other communicable diseases where maybe they might be waterborne or foodborne or fecal-borne or body fluids, where we can be uncomfortable, but we can separate ourselves from them, we can't opt out of air. We breathe in and out 12 times per minute, 720 times an hour, 24 hours a day, till the day we die. We are Homo sapiens. We are humans. So very concerning. We had a second outbreak in 2012, the MERS outbreak, Middle Eastern Respiratory Syndrome, by and large able to be contained to Saudi Arabia. But the alarm bells are really ringing now in the scientific community. So by the time we get to 2020, these are both coronaviruses, 2003, 2012. So we've been warned twice. By the time we get to 2020, 17 years of research has been done. All of the preclinical data has been done. All of the bench work research has been completed. The entire genomic sequence, all 30,000 base pairs have been identified and analyzed. And the mechanism of action, that spike protein connecting to these angiotensin converting enzyme receptors of our cells, has already been identified. All of that was done before we ever had our very first case. So we have to remember, behind the scenes in science, there's another world that's going on in that industry. And so even though it seemed to come to the public immediately, scientists have been working on it since 2003.
That's really interesting, because now we're starting to think about vaccination of our children from 12, to 17 years old. And so if we're not comfortable with it as adults, it's going to be hard to message that same information to parents that may be on the sidelines for themselves. But then, we have to think about this in terms of, are vaccination cards going to be necessary? I was also looking and reading the other day, and I'm seeing how dogs are learning how to sniff COVID in airports. Dogs are sniffing COVID. They're being trained at the University of Pennsylvania. And so I thought that was, wow, do we need to bring dogs to our church?
That is why. What
so
does smell like?
Can we get this job? And, do we show up? Well, yeah, what does COVID smell like?
What does COVID smell like?
I don't know, but I just know that this isn't the end of it. And it's gearing up to where, unless we have a vaccination card, proof of vaccination, we can't get a job, or we can get a job. It's just gone beyond just what we know about vaccinations. And I think that's making a lot of the community so uncomfortable about it. The issues surrounding, we have a lot of, Dr. Morgan, we have a lot of preachers on this, in these boxes here. And, the mark of the beast readily comes up, because among our constituents in our Pentecostal assembly, we have to think about, end time message and what the mark of the beast means, and the buy, sell, and trade. So I won't get into a whole notion of the theological constructs of it. But what's interesting to me is, how do we set our minds to deal with that? Because that's real stuff for us in our spheres. I happen to exist in two worlds, the world of science and the world of faith. So my challenge sometimes is to merge those two and make sure, I'm giving due justice to both. So maybe you could share, Dr. Wright, but how you walk that experience. I know that's probably same is true for you as well.
Yes, that you raise a very good point there. One thing that I try to tell not only patients but people of faith is that I see God as the source of all knowledge. So even what we are deeming as medical science is a knowledge base that comes from God. Now, of course, not everyone may buy into that, but I think there's truth and validity there. And, I also try to let people know that what we have available, to look at all the things that are available today to lengthen life and improve the quality of life. I often use my grandmother, well, both of my grandmothers are deceased, but my paternal grandmother, I really believe that she died too soon. She had, by the time we realized all of the medical conditions that she had, because she started going to or seeking medical help late in the process of these disorders. Uh, Sad to say, it was almost too late, and so there were a series of things that happened. She had an AKA because her diabetes was very bad. We didn't even know she had diabetes, and that following that there were strokes and other things that led to kidney failure, and ultimately her death. But she was a woman of strong faith, but I think it's somewhat unfortunate that she was the type that didn't seek medical help or medical treatment for anything, because she had faith and was believing God. But I think now that we've evolved in a sense to the point where there are these things available, ways to diagnose and treat things early on and prevent some of these bad outcomes. I try to have people to focus on that.
And Dr. Wright, I think you're absolutely correct that especially from the church community, you probably would have a better outcome getting people to understand that we may not know a lot about this virus. There may be conspiracies, there may be untruths being told. We may not be able to trust the scientists and the politicians, but one thing we do know is that we can trust God. And if people are coming from that perspective, I think it's very important that we meet them there and that we address the issue from that perspective. And hopefully, and I believe that many people will understand that God is in control, that no matter what we think, no matter what other people's agendas may be, God is still in control. And many people will move forward in getting the vaccine. That doesn't mean they're going to be a part of research and trials, but I think that they would be more willing to get the vaccine and understand that, God is in control, and he can, I've had people say that he can make the vaccine do what it's supposed to do, and any side effects he can, turn away from my direction. So I think that for many people, you are absolutely correct.
Yeah, I agree with that. Go ahead, Dr. K.
I was going to say, we also have to look at it from the other perspective of, is it really faith, or are we operating according to fears of past generations? Because my grandfather wouldn't let a nurse come in and do anything to him as a 91-year-old before he died. He just did not trust anybody that spoke words that he didn't understand. There was always this mistrust that I believe passes down from generation to generation. And we're calling it faith in God, but it's actually fear, of what God has given these individuals in terms of doctors and, scientists, the knowledge to be able to help us with. So, we also have to teach people from that perspective. It's great to have faith, but make sure it's faith indeed and not fear. The fact that you're afraid and this is your only, this is your default, this is your backup. I got to have faith because I'm actually fearful.
But Dr. Key, when you think about it, I want a physician, when they talk to me, that they can explain it in layman's term too. I don't want a physician to come to me and talk to me about things that I don't understand. They have to be able to break it down. And if a physician can't break it down, I don't know if that's the one that's for me.
And I get that for a person who, feels confident enough to say that to a doctor. But my grandfather was intimidated by people who were educated.
But Dr. Keith, whether you're comfortable enough to say it, I think as a physician, that's just like as a psychologist. I'm not going to use clinical terms and think that my patients understand that. It's my responsibility as a clinician to break things down and make sure that my patients are understanding it. And if I'm not able to do that, then again, I will even say for me, maybe I'm not the person for them. You know, especially when you're dealing with elderly people, you have to take time. You have to explain things to them. You have to give them an opportunity to ask questions. So again, I wouldn't put that on the patient. I would put that on the provider.
But the provider could be intentionally breaking it down as much as they feel like they can, and feel like they've done a good job of that. And the person still doesn't understand. And they're afraid to say, can you clarify it some more? You know what I mean? I think doctors in general, they try the best to not use jargon from their discipline. But, there are chances where even in the breakdown, it's still hard to understand. Tell it to me one more time, and they won't even say that.
And
So
I agree with you. I agree with you, especially when you're dealing with elderly people. My mom just passed and she was 94. But when her physicians would say something, I would say, no, you need to explain that to her a little bit better. So I agree with you that there can be cases where a provider actually does break it down, and maybe an elderly person or may not know how to say, I still don't understand.
And so there's that fear, there's that mistrust that a lot of times is passed down. And people operate according to the fears of past generations. They have to unlearn that. They have to identify that might be what's going on, before they can just say, I'm just having faith in God. No, you're scared.
One of my greatest challenges, opportunities, was growing up in a Pentecostal home where my father was a pastor, and he was a man of faith. And, at the time growing up, the youngest of 12, we grew up with very humble beginnings. So our health insurance policy was actually a prayer cloth, if you know what I mean, in terms of just getting in prayer lines and just to oversimplify it. So I grew up with the notion of praying about everything. And then I went to medical school. And so, but I couldn't just leave that behind, what I understood about faith. I didn't get it confused. I just really understood that faith augmented what I really knew spiritually. Here's the deal. So when I would go through life and go through medical school, I just felt like I had a better understanding of all of God's provisions, his provisions. And so they weren't mutually exclusive. They were, compatible and complementary. And so at the end of the day, it is still him healing. It is still him, restoring. And so when you put things in perspective and understand that as a person of faith, and at the same time, a scientist, I think it's a beautiful opportunity to really help our congregations and help our faith community understand, where this is coming from. We're instruments like eyeglasses, it's like insulin. It's all a part of the healing process. And so I think if we just kind of help people understand, really with the virus, the vaccines are another part of safety protection, helping us to see, helping us to live better, helping us to get on with life. It's really putting it in perspective.
Yeah.
Yes, I agree. Yeah.
As we were talking, I couldn't help but think that the first time I went to Africa, they required that I have a yellow fever shot, and how I didn't think twice about it. I'm just thinking to myself, I don't even know what yellow fever is. I never had yellow fever. I didn't know whether I could die from it. They just said, you need the shot in order to go on this mission trip. I just got the shot. And I'm thinking to myself, what is it now? Because that was about 11 years ago. That might be different with me. And, I often talk about how, as the older you get and the more you experience life, the more frail the more knowledgeable you become about your own frailties. There was a time where I would get on a swing and swing so high that it almost looked like I would wrap around the swing bar. I can't do that now. I get on the swing. I'm scared to swing just a little bit. What happened? I feel like I learned too much, or I've experienced too much. And now there's this fear there because I realize how frail I actually am. And I think that could be the same thing going on as people are getting older, as people have experienced life. They realize that they're not invincible.
Dr. Key, do you think it's more or less that your fear of getting yellow fever, even though you don't know anything about it, is greater than not getting it? You take the shot because you have such a great fear of getting it. And maybe with COVID, people are not all that afraid of it. You know what I'm saying? They're afraid of, but they're not It's not to the extent like you said, because I agree with you. When I went to South Africa, well, not South Africa, to the Congo, I took the yellow fever shot without thinking twice about it because I didn't want to get whatever they had there. I just didn't want to get it.
I don't think I had that thinking then. I probably would have that thinking now. For me, it was just like, another layer of protection. I mean, I didn't have enough knowledge about it or fear about it, or didn't know anybody who had suffered from it for me to be like, I better get this shot. If they had given me an option, I might not have gotten the shot.
Yeah. I think it's reflective of the triangle that Dr. Morgan described, that politicizing the virus, the misinformation, the distrust in that administration, it was just so racially charged. And I think we just felt like it just brought back to us in mind the Tuskegee experiment, Henrietta Lacks issue, the J. Marion Sims, all of that medical distrust that we once had. I think that's really what set us back. And, that's what, you talked a little bit too, Dr. Morgan, about how we as African Americans have an opportunity to, participate in the trials. How does that impact or help our, if we're participating or our lack of participation, how does that impact us? And, we're thinking when we show up to get a shot, we're thinking about the policing. We're thinking about George Floyd. We're thinking about all of those things that have happened to us in past time. And so we bring all of that with us when we roll up our sleeves. And then now the opportunity to participate in trials help us marry, understand how that impacts us favorably or unfavorably not to participate.
Yeah, we absolutely bring all of that with us. And it's one of the reasons why 80% of African Americans are seen by African American physicians, because we need somebody who has some cultural congruence and some place that we feel comfortable, and a place where people can speak to us and not at us, where we feel comfortable asking questions, where we don't feel intimidated. When we look at clinical trials as well, because of all the things, Dr. James Marion Sims, Tuskegee experiment, Henrietta Lacks, on and on and on, one atrocity after another, the sacrifices, the involuntary sacrifices that African Americans have made to the advancement of medicine and science. And we clearly understand that. Mm-hmm. But when we look at clinical trials, and we certainly look at social determinants of health and health equity, and the loss of 3 years of our life from this one pandemic, we have to begin to think about clinical trials and why we don't participate in them. And we know why we don't, but I'm going to give you an argument for why we should, or why we should at least start to consider it. If you are participating in clinical trials, not only do you have a physician that's overseeing you, that physician has a regional physician that's overseeing she or he, and that regional physician has a national physician. So there are 3 doctors that are watching you. You also then have your research coordinator or your nurse coordinator with whom you have a 24-hour contact information. You can call or contact that person at any time of day or night for anything that you want. You sneezed, you lost a hair, you broke your glasses, whatever you want to talk about, because we need that data to be clean. Not only that, if you are uninsured or underinsured, this is how you get medical care. The drug companies will cover the cost of your medications and care while you're in these trials. And oftentimes the follow-up period for these trials can be 1 and 2 years, where they're just following up on you. So we have to begin to think about what that means with regard to healthcare. Additionally, when we look at the rates of cancer in our community, we have higher rates of prostate cancer, colon cancer, some types of breast cancer. We know that cancer or oncology clinical trials, people who participate in those trials have an increased rate of remission of their disease. We absolutely know that scientifically. And yet white men are the ones who enroll in these trials. The data on white men is what gets approved by the FDA, but it gets primarily used on us. And we didn't participate in the trials, and the trials could have prolonged our lives. I mean, it starts to be just unconscionable. So Dr. Key makes a good point in that since the Tuskegee experiment, there hasn't been any new information for us to replace since then. We're still thinking about the Tuskegee experiment, and we've got to begin to move from exploitation to representation. And what does that mean in healthcare? We cannot continue to allow these drugs and vaccines and devices to be developed without any information on us. And the first time that we are exposed to them is in the real world situation when your doctor is prescribing it. And then you start having side effects when you're at Disneyland or you're on a cruise. You don't have a 24-hour access number to contact anybody. You don't have 3 doctors overseeing you. You're just on your own because you didn't participate. And so the data that went to the FDA may or may not be relevant to you. Let's see what happens. The big experiment is when your doctor's writing the prescription. That's the experiment if we didn't participate in clinical trials. And so we've got to begin to fill in some additional information since the Tuskegee experiment and begin to understand how this closes the gap on health equity, how we can access health care. We don't have insurance, so we're underinsured. There's the dirty little secret.
That's good.
At least for oncology trials, for cancer trials, how could we not participate in cancer trials that the trial itself could prolong your life? Is 3 weeks of extra life worth anything to you? Is another 6 weeks of your mother's life worth anything? That time, how much is time worth to you? And we don't even, not only when the chemotherapeutic drugs are approved, they don't have our data in them. We don't even participate in the trials that have clearly been shown to increase remission. I mean, it starts to be just unfathomable for someone, especially like me, a scientist, to understand. And we've got to begin to replace that information of the Tuskegee experiment that happened. Absolutely not forgivable. I want to be clear about that. The use of Black bodies for research, absolutely unconscionable.
And Dr. Morgan, can I just say this?
With this new information of moving forward to what does health equity look like in 2021, 2022, and how do we need to adjust our thinking with clinical trials and oversight?
Dr. Morgan, I the way that you said that connected with me, as an individual and also as a professional. And I think if I would come from that perspective with my patients, they could feel me. Because what you've done is you've acknowledged what has happened to us as a people. But then also you dealt with me from a very personal perspective of the benefits that it would give me as an individual, what it would give my loved ones as an individual. And I think just hearing you from that perspective, I would be more apt to listen and be a part of it, as opposed to the statistics about what the pharmaceutical people say or what the government says. And, just solely from a scientific perspective, I think what you said was really good and would, even from this perspective, may even help people get the vaccine, would help people be a part of the COVID research. You really touched home in a very personal place with the way that you explained it this way.
Great.
So thank you for that.
That's great. Thank you so much.
And I feel that it has to even go further back so that when they do come to someone like us, a psychologist, they're primed already to understand when we even say the word clinical trials, because I don't think many of us know what a clinical trial is. Honestly, we don't grow up being exposed to the idea of, hey, if we're going to see if something is valid or works, we have to try it first. and somebody has to be willing to volunteer for that trial. Oftentimes when we hear clinical trials, it's like last resort, nothing else has worked for you. Do you want to try this? It's not approved yet, but this could be your only hope. That's when we find out about clinical trials. But if you had told me about clinical trial in elementary school and high school and what my contribution would do for my community moving forward, I would be primed when the situation came up. When I hear of new studies, I'm sitting on the subway in Philly and I see the little poster on the subway wall that says clinical trial. I might be willing to look into it and see how many of us are actually participating in it.
And one of the things you made a really good point, Dr. Key, is that, the other thing to maybe ask yourself and ask your patients, where would you rather have side effects of your drug? You want to have them within a controlled environment with 24-hour access and people overseeing you and ready to jump in? Or you want to just have them when the drug is available and you're just kind of out on your own at the supermarket? I mean, where would you rather have side effects? I've heard people say, I don't want to be in clinical trials. I might have a side effect. But if you don't participate in a clinical trial, you might have one on the other end. So you've got to weigh that risk-benefit ratio. And the other thing that I will add is when we looked at the former president, Donald Trump, when he contracted COVID-19 and he was sitting in that White House, 74 years old, overweight, desaturating, oxygen levels dropping, the medical community clearly understood that he was on a downward trajectory, regardless of the shameful wall that his physicians placed in front of him with their lack of informationals. He was then airlifted to Walter Reed Hospital, where what happened? He received a drug that is within a clinical trial. He received Regeneron's monoclonal antibody therapy. Nobody had ever heard of it. You know why? Because it's only available to people in clinical trials. He received it under emergency use authorization as the president of the United States. And the only other people who got that life-saving drug were people who were in the clinical trial. That monoclonal antibody is credited with interrupting his downward trajectory. That's platinum healthcare.
Well,
going to your physician and you are not being offered a clinical trial and you are managing a chronic medical condition, then you are being treated optimally to the best of what we have that's FDA approved, but you're not being treated maximally. Donald Trump demonstrated what I talk about all the time. That's the care that's behind the curtain that Black people don't access. That was platinum level healthcare. We don't get that.
You're right, Dr. Morgan. But is the onus on us or is the onus on the medical industry? Because in our practices, a lot of times, unless we're sitting, people have severe disease, we don't always have those clinical trial stations in our community. So should the healthcare industry, research institutions be doing more to make the African-American community aware of what's available? We have to move again from exploitation to representation. What's our on-ramp? And maybe they should make the on-ramp more visible to us so that we can begin to engage as, and just maybe expose it in our churches, expose it in our salons, and, just, make sure that we're endorsing something, but we don't have those on-ramps. So what would you say a strategy could be so that we can begin to view our options for participation?
Absolutely. And maybe you should co-write the paper with me, because I wrote a paper and I outlined these very things. It's multifactorial. We have responsibility. We have responsibility in our mindset, and it's not our fault. I'm not blaming us. I'm only acknowledging we've had no information since the Tuskegee experiment. That was the last time we heard about clinical trials, right? We haven't heard anything since then. So how can we be expected to participate? It's also on the onus, and I've written this publicly, so I will say, and it's been published, that these companies must begin to recruit Black physicians to be principal investigators, recruit them and train them. Principal investigators of these trials, 98% are white men. And yet 80% of our Black population is seen by Black physicians. So you can see already why we won't participate. We also know that the number one reason that people of all colors participate in trials is that they are approached by a trusted physician. So if our physicians are African Americans and 98% of people who are principal investigators in trials are white, we're never going to be approached because our doctors don't even participate. So, multi-layered, but again, starting from the bottom up and from the top down, from the bottom up, as patients, we can ask our doctors, hey, I'd like to think about a clinical trial. What do you know about it? You can push them. Oh, I don't really know much about it. We don't have them. Let me reach out to our local medical center. Let me see what I can find out. You can push your doctors. At the same time, your doctors can volunteer for training to be principal investigators. At the same time, the companies need to reach out. We need to see leadership in research that looks like you and me, people who have a voice at the table, people who are overseeing health equity, who can ensure that it's baked into the cake when we are developing and writing these protocols, that they include study sites that go out across the mass, that's the mosaic of America, and not just these medical centers. So lots and lots and lots of areas, as you can imagine, something that's 400 years in the making, hard to unravel it in a few months, but all of us can begin to lend our voice to understand that. And as just patients, we can start by asking our doctors, hey, you have a clinical trial? You might say, oh, you're not that sick. I don't need to be that sick. I would like to participate in a clinical trial. I'd like to at least know if there's something available to me. And here's the other thing. In some trials, especially uninsured and uninsured, this might be of interest. In some trials, you do receive a stipend for participating in the trial. So outright cash is also paid oftentimes to participants in the trials. So something just to consider.
Can I ask you, Dr. Morgan or Dr. Robertson, Dr. Wright, do you find that Black physicians also suffer with distrust, even though they know the science, but distrust of clinical trials, and find themselves maybe subconsciously not offering it or staying away from it because deep down inside they feel maybe that his patients are being used as guinea pigs?
Absolutely. I think Black physicians feel a responsibility to protect our flock, right? Protect our own. But then you also have to remember, in addition to that, Black physicians experience a lot of discrimination and racism within the medical system themselves. And the stress of having to constantly manage that, people not addressing them as doctor, people not including them in the conferences, people not inviting them to grand rounds. You're not getting the referrals that you should. You're constantly working against the racism of the system, even to practice. That is a heavy stress. And then the burden, and I don't use that word lightly, of serving your community and all that comes with it. Is not just medical, it's the psychological, it's the social, it's everything that comes through that door. All the families, the burden of that, and having to constantly represent and advocate for your patients, I think is, a large stress on African Americans. Recently, there was a paper published just on cardiologists, which I am. I am a cardiologist, Black cardiologists, and the degree to which we experience racism amongst our colleagues in the system. That was a scientific paper, and female Black cardiologists, of course, at the highest, because cardiology is a very white, male dominated system. And so sometimes I know you're looking at your doctor as the person you've come to receive care, but that person also behind the scenes has to survive in that system just so he or she can provide the best care for you. So I think you are correct, because just because you put on a white coat and an MD, I think we can see, the police will gun you down. They will do whatever. So we know, and you can be gunned down in the medical system in a euphemistic way. So all of that, comes to bear, the physician is managing all of that as well.
I'm glad to hear you say all this, Dr. Morgan. I'm a believer in clinical trials, but I was not aware of the process I would need to go through to become, as you said, a principal investigator. And so this has been very encouraging to me to be more proactive. I've heard of ways for patients to be involved in clinical trials, but sometimes it seems I come across that information accidentally. Hey, if you want to sign up for a clinical trial to about a new or investigatory blood sugar medication or something like that. It seems like I'm coming across that information again accidentally, whether it's something
No,
in the news.
not only is it accidentally, it wasn't intended for you.
Yeah, exactly.
It's random.
Yeah, so
That's right.
I'm glad to hear you say that.
And we need to stop allowing medicine in this country to be practiced that way.
Yeah, yeah. And then therein breeds the distrust. So there's some distrust that we have, and that of course gets impacted and rolled over into our patients' distrust. We have a lot of work to do. But this has just been great information. But as we come to the end, I'm just wondering, Dr. Morgan, you're speaking on so many different platforms and so many different outlets, and have done so much work in this field as a COVID task force clinical director. What are some of your personal fears? What are some of the things that make you weary about where we are now as clinicians, as African Americans, moving forward and moving beyond the pandemic? What keeps you up at night with all of this?
Yeah, so I think one of the things that concerns me a lot is the lack of upward career movement, ability, and opportunities for Black physicians. Certainly within hospital environments where we see staff, oftentimes they are people who make money for the hospital. So basically what I'm saying is the Black physicians and the Black nurses, right? But you can't be the CEO. You can't be the vice president. You can't be in any of the seats that are making decisions that impact the doctors that are admitting to your hospital. We will give you hospital privileges. Really? That's a quid pro quo, because I'm making money for you. I'm bringing my patients in here. But you can't have a seat at the table when decisions are being made about what happens. So when we look at the leadership of hospitals, the higher you get, the whiter it gets. Very, very, very white. There's no representation, not only in medical systems, but also the pharma companies, the drug companies, everywhere we go. So if we don't have these opportunities for leadership, and we rarely do, so we've got to begin to advocate for them. We need to begin to develop allies and networks of all races and make it clear where we want to go with our careers. Because unfortunately, and I say this as a burden, and it's a responsibility, wherever we go, we're representing everybody. Isn't that true? And so we can't just, be Jane. I have to also represent the rest of the race that's going to be there. I need to understand what's happening in this boardroom in case, I don't want to be a part of something that's going to negatively impact my community. But then you've got to be brave enough to speak up, because you're the only one. And if you speak up, maybe then there'll be nobody, because then you'll be gone. And so these are the things that we have to constantly manage. And so if you talk about things that keep me up, it's the lack of opportunity for Black medical professionals to advance, such that we really can begin to have a voice. And it needs to be more than the token one. The token one is just that, the token. The reason, not because there's anything wrong with that person, because that person isn't empowered. And they're fearful of speaking up and speaking out because of the repercussions, meaning, you can be isolated, you can be excommunicated, you can be fired, you can be given the less desirable assignments, all kinds of reasons that you're punished And so you end up going along, but that doesn't help anybody. And that's how you become the token. There has to be more than one. There's enough light to shine on all of our faces. And we need to get there. We need to bring other people there, because those people will help us have the courage to continue to speak up and represent our community, and our community, not just the Black community, but all of America. It's all of our community, but also our Black community. We have the privilege of being able to speak both languages. We have a foot in both worlds. We are incredibly valuable. We can represent everybody, unlike most white people can only represent one swath. They never live in two worlds. We always live in two worlds.
That's great. And I guess now we can say Black Lives Matter, even in healthcare, even among healthcare providers, particularly. Thank you for that. That's incredible. That's encouraging for all of us. And in our last couple of minutes, I just like for each of you panelists, Dr. Key, Dr. Douglas, Dr. Wright, and you as well, just to give us, your final summations and just some things that you think moving forward, has been helpful for you this morning, and or what's keeping you up at night as well. Dr. Douglas? She may be frozen, but go ahead, whomever, Dr. Key, sure.
Yeah, I just wanted to say how helpful this has been for me. I think one of the things that I would suggest and push regarding the Black and Brown community is to not be afraid to ask questions. That we're not having this panel, this roundtable, simply because it's something to do. But your questions are valuable, your concerns are valuable, your fears are valuable, and if we don't know them, if we don't speak them out, then things are destined to continue as is, and that's not what we want. To Dr. Morgan's point about being afraid to speak up, I know what it's like to live, of course, in this, psychology clinical world, and also as a Black male, but also as an individual of faith, and I speak multiple languages. I have a degree in business. I speak multiple languages, and people need to understand that when you can communicate in these several different realms, that you are valuable, and that starts with you, that we are value added, and we need not to back down, just because they don't want to hear, or they're intimidated, or they're uncomfortable with our willingness to speak up. So, this has been beneficial today. People, ask your questions, speak up. That's what I would have to say right now.
Thank you so much. I think we're running fastly out of time. Go ahead.
Yeah, I just want to say, Dr. Morgan, thank you for exploitation to representation. The preacher side of me is going to use that.
Thank you so much.
I'm humbled. Yay.
Dr. Douglas, in the last 30 seconds, if you're on. I think, Dr. Douglas, the last 30 seconds, if you're on.
Yes, I was just going to say that I have truly enjoyed the roundtable. I want to thank everybody for participating. The thing that was most enlightening to me is the way that Dr. Morgan explained the reason why we should participate in clinical trials. And from that perspective, I will be talking to my patients about the importance of being a part of clinical trials and not just waiting for them to become severely ill, but as far as the benefits of it. So I appreciate everyone's input.
Thank you.
You're muted, Dr. Robertson.
Okay, thank you. Thank you so much. We are at the end of the line. And Dr. Morgan, thank you so much for being with us this morning. You inspired us, encouraged us, and we got to show up. I think that's the thing. And then my thing is Black Lives Matter, even in the platform, even in the boardrooms, and even in the hospitals among our patients. And so it's up to us a lot of times to help to move our community forward. And we want to assume that role with being able to do that. Thank you, community. Thank you, PAW, for allowing this space. Bishop Brooks, Bishop Harrison, has been wonderful. And look forward to answers to your questions online. We're going to be answering those. And then also we're going to have a second panel Again, Dr. Morgan will be joining us. We'll talk about what the PAW will be doing as it relates to the COVID vaccine and our positions and our endorsement regarding that. Thank you. Have a wonderful rest of your morning. God
Dr.
bless.
Robertson, I'll just add one thing. If anybody wants to follow me for science information, you can follow me at Dr. J. Morgan on Instagram, Twitter, or LinkedIn. I do a series called Sterile Chronicles. 1 minute I take to answer COVID vaccine questions in 60 seconds or less. I answer a COVID vaccine question. You are welcome to access any of the catalog of any of those 1 minute videos. They're called Sterile Chronicles. I sit on the steps and I just talk to you like your neighbor, straight talk. Answer the question in 60 seconds.
Stairwell, STAIR.
Yes,
Well,
Sterile Chronicles.
Wonderful. Thank you. Thank you. And also, Dr. Wright, I think what's you're followed on Instagram. What are your platforms?
Instagram, Facebook. I also have a small YouTube channel just with little bit of content right now. I'm trying to beef that up a little bit. So.
Awesome. Dr. Douglas?
Sorry, Facebook and Instagram.
Facebook and Instagram.
Now with
All
Facebook,
right.
it's Karen Rowland Douglas.
Karen Rowland Douglas. This has been great. Thank you, everybody. And we look forward to the rest of the conversation. This is only the beginning. There's more in store. So we hope you'll continue to be with us. God bless. Dr. Key, you're there. All right.
I don't know what happened. It just cut on me. And I'm still here.
Wonderful.